Both sets of infections had effects outside the primary organ of infection, and in both cases there was a prolonged increase in cardiovascular mortality, presumably related to a pro-inflammatory state generated by the primary infection. And finally, there are gaps in our knowledge in relation to both of these and the need for more research.
Thank you. Would you like to add on?
I was particularly struck by Dr. Somia's statement that we actually previously didn't use to test for viruses. And life changed a lot since COVID-19 because suddenly even low to middle income countries now have capability to test for viruses, and that's really enhanced our ability to detect viral illnesses. So I think there's so much that needs to be done when we look at respiratory infections in adults. In kids, they already have been routinely testing for viruses for some time, and viruses have been the predominant cause of respiratory diseases in kids. And for places for studies that have been done, half of all respiratory illnesses resulting in hospital admissions are actually caused by viruses. And by treating them with antibiotics the way we do, we are actually increasing the antibiotic resistance in particularly low middle income countries. So I think there really needs to be a lot more push in screening for respiratory viruses when patients come in with respiratory illnesses to hospital, so to actually reduce unnecessary use of antibiotics. I think that's the main take message for me.
As regards the H. pylori, excellent presentation. You've got a good overview of this very time. H. pylori was in early 80s when H. pylori kind of came up. All the meetings were all about it. But as the time has passed, I think the interest, I have to say, in H. pylori has gone down. It's partly because I think the overall incidence of H. pylori in the western part of the world has gone down. Maybe still in Pakistan it still is quite common. One thing I have to say that the practices change with the passage of time. I just want to share that in UK, the non-invasive test of urea breath test has almost disappeared now. We don't do it. Mostly rely on stool H. pylori antigen. And I think it's important that you educate your patients that this is not that cumbersome test. It is, I think it has happened gradually even in UK because people were initially concerned about it. But it's a very simple test, and I think the falls, and I think it's not that expensive. For urea plus test, you have to have the whole kind of mechanism to do it. And in relation to, it's also very important that we do that test with all the precautions. The patient must be off the PPI and antibiotic for at least 2 weeks before you do it. Otherwise, you will get false negative tests. As regards the treatment, I think the spectrum varies, and I think he's given an excellent views about it. We tend to use mostly non-triple therapy for a little shorter period, but maybe I think in Pakistan it may be a different experience. But I think as far as the long-term, I quite agree with him. Patient asymptomatic cases, I think this probably is not cost-effective, and probably not, to some extent, the present evidence appropriate. So with that, I would like to really thank all the speakers and my co-chairs who have got a word of experience about respiratory condition. I've learned a lot from you guys. And look forward to see you tomorrow. Is that the end? Is that something any announcement you have to make?
Yes, sir. Obviously, I have a little announcement to make. First of all, I would like to extend my deepest thanks to our body chairperson and our respected colleagues and our speakers. Indeed, fight against infectious disease is a constant struggle, but a winnable one.
With this message, I would like to conclude this session for the right time, at the right moment. This session is followed by another session on artificial intelligence in Hall B, 6:30 p.m. sharp.
This is the sixth convocation. However, this is the fifth annual conference. One convocation was held in UK when a special convocation was held because of an overseas conference which was organized by the UK doctors, and Professor Javed Akram and select people attended that. This fellowship award is to recognize excellence, and in recognition of excellence, it also encourages young, ambitious physicians to follow the others and achieve excellence. And I will quote Aristotle: excellence is a habit and it is not an act. So we are trying to develop this. One of the other reasons of holding this fellowship is to bring together this large fraternity of doctors from across Pakistan and around the world. Now I will request the President of the Pakistan Society of Internal Medicine to address the convocation. Sir, please.
Once again, Bismillahirrahmanirrahim. Assalamu alaikum, good evening to everybody, especially the Honorable Chief Guest, Mr. Justice Sheikh Shahid Wahid, very senior judge of the Apex Court, the Supreme Court of Pakistan, the convocation chair, Professor Aftab Mohsin, the recipients of the fellowship, and ladies and gentlemen. Why PSIM started this convocation, and also why we are holding it regularly. Because not all organizations will do that, some will do it. Pakistan Society of Internal Medicine is a fairly young society. We are less than 5 years old. But why one of the objectives of having PSIM or Pakistan Society of Internal Medicine is that as an internist, I was feeling that out. Because there was the glory which was there when I was studying at undergraduate level at my alma mater, King Edward Medical College. At that time it was a college, later on it became a university. So very tall figures in internal medicine were there, and everybody wanted to be internist. But then the time came of specialization and then supra-specialization. And everybody wanted to be a specialist in cardiology, nephrology or whatever. And we were falling apart the internal medicine. So, since we are also patient-centric, I believe I see patients as internists who are diabetics, who are having cardiac failure, who are having different varied diseases. And for example, a diabetic will shuttle from one doctor to the other. For his kidney, he will go to a nephrologist. For his heart failure, he will go to a cardiologist. He will give him diuretics, he will stop the diuretics. And then he will go to a neurologist. So, being patient-centric organization, we think more than 90% of these patients who have complications, they can be dealt with. And then it's up to us to refer them to a specialist, a different specialist if need be. So that was one reason. And the other reason was that at an undergraduate level, in Pakistan at least, we do not expose our students to specializations. They only, internal medicine teaches them medicine. And then if you go to any medical school here, there will be 4 or 6 medical units because they are taking all the emergency. And there will be 1 cardiology unit, 1 neurology unit. So the bulk of the patient load is being catered by internists. And it was very, very important to bring the glory back, which I am very thankful to my Almighty Allah that this is happening. That now people are opting in the medical school to be internist. This is our contribution to this specialty. And this is, I think, not the goal achieved, but I think we are moving in the right direction. And this convocation is one of our interventions that we have tried. So that's the reason, and especially giving the fellowship to very, very towering figures who are here in the first line, second line. Some of them sitting there, my dear friends, who are not being given right now, but they are also equally towering. And we have the galaxy of physicians from all over the world, starting from New Zealand to US, in between everything. So we all are here to learn from each other and to bring the best treatment options to our patients. Evidence-based medicine is our motto, and that is what we feel we need. That's why we need, because the new evidence keeps on pouring in. I, as a medical student, or as a postgraduate student in UK and elsewhere, was never ever told about COVID. I never heard of it. As a teacher, I never heard of it, and I taught in many countries. But suddenly, we were hit by COVID. So it exposed us at how updated we need to be. The medicine, internal medicine, in the next 10 years will change more than it has changed in the last 100 years. So that's the reason for these conferences, and that's the reason for bringing these collection of speakers to impart this knowledge and discuss with us the different treatment options. So we want to practice the medicine of 2024, not the medicine of 2000. So that's the reason, because there's so much data coming in from evidence which we need to interpret it and deliver to the patient, because we claim that we are patient-centric. That's extremely important to us. Our lives revolve around the patient. We are doctors because of these patients, irrespective of whether they can afford us or not. They cannot, from the base of the pyramid, especially in a country where there are few very rich people, very, very rich people, and then it's the pyramid, base pyramid, where people cannot imagine being treated by a specialist, cannot imagine getting their HbA1c and their test done because they don't have money, and then cannot afford the treatment at all. There's several salaries involved in the treatment of diabetes, if there are insulin or GLP, whatever. So we have to go to the base of the pyramid and then be available to them, irrespective of whether they can afford us or not. And that's exactly what PSIM is doing. And you know, I'm proud of everything that my team is doing. The credit goes to them, not to me. If there is anything which we could not accomplish, I am able to do. But this team, the best thing that they have done, which is very close to my heart, is develop a network of cashless tertiary care clinics, where not only our consultation is free, but we call them Aapka Clinic in Urdu, with all my apologies to my colleagues from abroad. This is a name that is in illiterate people who are not that much, they also know. And these are cashless clinics where first and foremost the place needs to be in a trust with Almighty Allah, with God, so that the property is mutated first, because when we die, we don't want whoever is given his property, his children becomes claimant. So this is irreversibly, and we are the workers here. We all work, all of them give time. And then all the investigations are free of cost, whether it is radiological, whether it is biomedical. And then all the treatment for lifelong is free. We pledge as a society that we will ensure whether we live or not, the society pledges that these people right on the base of the pyramid, they will have continued supply of whatever they need. So that's what it is. I'm glad that this is sixth convocation because the organizations or any departments, everything, how they get all this strength? They get this strength if they bring in good traditions and convocation. This is an academic feast for me. I am humbled to be talking to the audience of this stature. So, if you bring in good traditions and keep those traditions following regularly, then that organization or that institute just strengthens. That is what we are there for as PSI. To really strengthen, because it is, number one, there is Pakistan name, my country's name there, and then internal medicine name. That's good enough reason for me to do whatever we can to achieve our objective. At the end, I'm very, very grateful to so many of you. In the interest of time, I'm not naming you, but really, I'm honored that you traveled so far anyway. And, I just hope that we come to your expectations, and I just hope that we can later on rest of it. Thank you so much.
President, Pakistan Society of Internal Medicine, Professor Junaid. President, Fellowship Committee, Professor Aftab Mohsin, distinguished fellows and faculty, ladies and gentlemen, Assalamu alaikum. It is a great honor and privilege that I stand before you today to inaugurate the fellowship ceremony of Pakistan Society of Internal Medicine. As we gather here, we celebrate not only the achievements of individuals, but also the collective dedication to advancing the field of medicine and healthcare. In this room, we are surrounded by brilliance, compassion, and unwavering commitment to the betterment of human health. Each one of you represents a beacon of hope, a source of healing, and a catalyst for changing the lives of countless individuals. Your tireless efforts, perseverance, and passion for medicine have brought you to this momentous occasion. Today marks not just the culmination of years of hard work and dedication, but also the beginning of a new chapter in your journey as medical professionals. As fellows of this esteemed society, you are entrusted with a profound responsibility, a responsibility to uphold the highest standards of ethics, integrity, and excellence in your practice. It is indeed a profound honor to address you on this momentous occasion of your inauguration. As a Supreme Court judge, I stand before you not only as a representative of the legal profession, but also as a fervent admirer of the noble calling to which you have dedicated your lives, the pursuit of healing and compassion. Ladies and gentlemen, Pakistan is facing immense challenges and amidst the uncertainty, instability, and economic strife, our healthcare sector has suffered the most. These challenges include, but are not limited to, limited access to healthcare services, infrastructure and equipment shortages of healthcare professionals, worsened by the perpetual brain drain, high disease burden coupled with inadequate health awareness and education, poor affordability and financial barriers. We have almost the highest maternal and infant mortality in the world, a situation worsened by the relentless growth in population. Providing quality of care is a persistent challenge in Pakistan. Issues such as medication errors, diagnostic inaccuracies, and substandard care contribute to a poor health outcomes and erode public trust in the healthcare system. I often ponder on COVID days. The cracks of our society laid bare by the pandemic disparities in our healthcare system, the atrocities of an economy so fragile that it could not withstand even a day of people staying home, the vulnerabilities of those living below the poverty line, crowded living situations, and overpopulated prison network, I ask all of you, the pandemic tried to teach us a lesson, but did we learn from it? But my dear fellows, in the face of such formidable challenges, you have emerged as a beacon of hope and healing, armed with expertise, dedication, and unwavering compassion. Specialists like you stand on the front line, tirelessly working to save lives and alleviate suffering. Despite resource constraints, infrastructure limitations, and systemic obstacles, you have shown resilience. In moments of uncertainty, you have demonstrated courage. And in times of adversity, you have exemplified compassion. These qualities, woven into the fabric of your character, will guide you as you navigate the complexities of modern healthcare and confront the myriad of challenges that lie ahead. From the bustling metropolises to the remote corners of the country, medical specialists serve as a pillar of strength, confronting diseases, injuries, and epidemics with courage and determination. Their commitment transcends boundaries of geography, ethnicity, and socio-economic status, offering solace to the sick and vulnerable. In their hands, lives are transformed, futures are safeguarded, and communities are empowered. Their work is not merely a profession but a calling, a noble pursuit that embodies the essence of humanity and the power of healing. As they navigate the complexities of the healthcare landscape, their unwavering dedication serves as a testament to the resilience of the human spirit and the boundless capacity for compassion. My dear fellows, as a member of the judiciary, I can assure you that we share many trials and tribulations and purpose. Both judges and medical doctors are entrusted with making critical decisions that can have significant impact on people's lives and often deaths. Judges make decisions in legal matters, ensuring justice and upholding the law, while doctors make decisions regarding patient care, diagnosis, and treatment aiming to promote health and well-being. Both professions require strong analytical skills to assess complex situations, evaluate evidence, and arrive at well-reasoned conclusions. Judges analyze legal arguments and precedents to reach judgments, while doctors analyze symptoms, medical tests, and research findings to diagnose and treat patients. Judges and medical doctors must adhere to high ethical standards in their respective fields. Both professions require integrity, impartiality, and commitment to upholding the rights and welfare of individuals. Judges ensure fairness and justice in legal proceedings, while doctors prioritize patient autonomy, beneficence, and non-maleficence in medical practice. Both professions entail a commitment to lifelong learning and professional development. Judges stay abreast of legal developments, precedents, and case law through ongoing education and training, while doctors engage in continuous medical education to stay updated on advances in medical knowledge, technologies, and treatments. Finally, both judges and medical doctors play vital roles in society, contributing to the administration of justice and the delivery of healthcare services, respectively. Their decisions and actions have far-reaching implications for individuals, communities, and the broader society, shaping laws, policies, and public health outcomes. In medical schools, they taught you to think like doctors, but I hope you never forget how also to think and feel like human beings. Because of all its rigorous standards and exacting procedures, the practice of medicine is a deeply personal and human endeavor. It is a delicate and demanding art at the end of which, when well practiced, is lived life and freedom from suffering and fear for our patients. My dear fellows, you are not only medical doctors. In my views, You are Sufis. You are Sufis or medical Sufis. I explain why. Sufism emphasizes spiritual growth, compassion, and interconnectedness. You practice the same thing. You foster a holistic approach to patient care that addresses not only physical ailments but also spiritual and emotional well-being. Sufi principles such as empathy, humility, and service to others are very present in your profession. You develop deep connections with patients, understand their unique needs, and provide care that is compassionate and culturally sensitive. Healthcare professionals manage stress and cultivate resilience. You are incredible people. In your journey in medical profession, you are endowed with a sacred trust, the trust of your patients, their families, and society at large. This trust is not merely bestowed upon you by virtue of your qualifications or expertise, but is earned through your unwavering commitment to the highest standards of integrity, ethics, and excellence in patient care. As you embark on this noble path, I urge you to never lose sight of the profound impact that your work can have on the lives of others. Each patient who crosses your threshold entrusts you with the most precious possession, their health, their well-being, and often their very lives. It is a responsibility that demands not only skill and knowledge, but also empathy, humility, and profound respect for the inherent dignity and worth of every human being. In the pursuit of your vocation, you will undoubtedly encounter challenges that will test your resolve, challenge your intellect, and sometimes shake your faith. But it is in these moments of adversity that your true character will shine brightest. It is in these moments that you dedicate to the oath you have taken to do no harm, to alleviate suffering, and to promote healing will be the most sorely tested. But let me assure you, dear fellows, that you do not walk this path alone. You are part of a vast and illustrious community of healers. A community bound together by a shared commitment to the service of humanity, a commitment that transcends borders, languages, and cultures. In your colleagues, you will find allies, mentors, and friends, sources of wisdom, inspiration, and support as you navigate the challenge and triumphs of your chosen profession. I also hope you will identify yourselves after today not only as doctors but also as activists, peacemakers, statespeople, ambassadors, innovators, philosophers, and above all, a great Sufi. As you stand on the threshold of this new chapter in your life, I offer you my heartfelt congratulations and my sincere wishes for success and fulfillment in the noble calling to which you have been called. May you always find joy in the practice of your art, may you always be guided by compassion, and may you always remain true to the highest ideals of your profession.
One starts to think that when we are managing diabetes, is there still any room for looking into medication in our patients? And majority of patients in Pakistan do have a room. And what we're going to see is that can we fit in one of the newer molecules in the management of diabetes if they require. So to illustrate in the interactive session, I thought, and I've just put a case here. And I think this is a very typical case of what we see in our practice in diabetes. This is a 55-year-old lady, diabetic for the last 10 years, has refused for the last 2 years to be started on insulin, and she's refused. A1C remains 7.5 on SU and metformin. I think this is a typical case what one would come across in the management of diabetes. Middle age, refusing insulin on 2 drugs, which is metformin and sulfonylurea. The symptoms include polyuria, polydipsia, blurred vision, dryness of eyes, lower extremity paresthesia, and occasionally lower extremity edema as well. Again, this is typical that somebody is catabolic. If they started to have a catabolic symptom, one needs to think that they probably need insulin to begin with. And this is the symptoms that she had. She had a strong family history of type 2 diabetes, hypertension and cardiovascular disease, and the medications are already there, metformin, glimepiride 2 mg twice daily, which I believe is almost a maximum dose. You can go up to 6 mg, but usually beyond 2 mg it is difficult to manage. Lisinopril 20 mg in the morning, etorastatin 10 mg at bedtime. A typical case one would come across. These are her numbers, 8.2. So from 7.2 she's crept up to 8.2 A1C. Glucose is high. There's a leak in the urine for albumin if you check, and the lipid profile is reasonable, but the cholesterol is slightly on a higher side with high TGs. LDL is reasonable. Krebs is 1.3, and she's got a high uric acid, and she's got a liver function which are 1.5 times the upper limit. So, in a scenario like this, do we see any role of SGLT2 inhibitors? The SGLT2 is a newer class of medications, sodium glucose transporter inhibitor. And what it does is that it blocks the reabsorption of glucose in the proximal tubules. So as a result, you'll have a glycosuria and you'll maintain the hemostasis of the glucose in the blood. So looking at these numbers, what do we have a role of SGLT2 in this? So looking at all the numbers, we thought, let's talk about hyperglycemia. There is hyperglycemia in that patient. The SGLT2 inhibitors which we are talking about, every drug in diabetes has got a power of reduction of the A1C. If you combine the drug with another drug, the power may increase. If you look at the different classes of SGLT2, we can see that it's from 0.4 to 0.6 to 0.9 or to 0.79. So this is the whole spectrum. So the efficacy of the drug is there. Whatever A1C you're starting with, there is a chance if you add this drug to reduce the hyperglycemia, and the reduction power is there. If you combine the two drugs together, suppose AMPA with Alina or AMPA with different doses, or DAPA for that matter. So if you combine the two drugs, the power of reduction of A1C is even higher. And this is what we have seen. So a lot of pharmaceuticals are bringing up these combinations, and one of the purposes is that the adjuvant of the two drugs will bring the A1C further down. So yes, if there's a hyperglycemia, if the patient is on metformin and SU, and the A1C is up, there is a room of bringing the A1C further down if you add another drug, which is AMPA, in our case, what we are discussing. Those of us who have used it, who have used this drug, we all know that this is a very powerful drug, empagliflozin. So I think looking at these numbers, for treating hyperglycemia, there's a room for using empagliflozin in this patient. What about microalbumin and lipid metabolism? Do we have a role? Yes, the patient is on lisinopril already, but despite that, there's a protein leak. So do we think that if we add a SGLT2 inhibitor, would we benefit this patient? This is the mechanism of action, how it works. So we know that SGLT2 have a reduction in A1C, weight, uric acid, blood pressure. We're going to talk about that. But there is also reduction in glomerular filtration by restoring the GFR. Initially, the GFR is increased, but later on, the reduction happens. But it has got effect on albuminuria, and it has got effect on tubular apoptosis. Some of the people earlier said that, if you are pouring too much glucose into the tubules, aren't you going to damage the tubules? So the example is that, the renal glycosuria, which happens to patients who doesn't have diabetes itself, their tubules are not damaged. And this is precisely how it works, that the tubular apoptosis is reduced when we are using SGLT2 in this. And that doesn't finish here, because if you look at the treatment algorithm of a patient with type 2 and CKD, and these are algorithms by ADA, European Association, and all that. What it does show is that if you've got a chronic kidney disease, one of the drugs which we prescribe is SGLT2 because it reduces the end-stage renal, it delays the end-stage renal disease for patients with type 2 diabetes. And this is another graph which shows it was actually, the trial was actually EMPA-REG, which was done for cardiovascular outcomes. But if you look at the patients this was a secondary analysis, what it shows that whether the patient has normal albuminuria, microalbuminuria or macroalbuminuria, in all the cases, the drug when it was introduced reduced the microalbuminuria in these patients. Does it have any effect on lipid metabolism? Yes, it does. And if you look, it increases actually LDL, but it also increases the HDL. What is important is that it reduces the small dense LDL cholesterol particles. We know that small dense LDL particles are the ones which are the troublesome. So overall, there's an atherosclerotic protective effect by increasing the LDL. It does cause increased lipolysis, and the chances of ketogenesis is there, which I'm going to discuss a bit later. But generally, it has got a better effect on lipid metabolism by reducing the lipid accumulation, reducing, very importantly, visceral fat. We as Asians have got a lot of visceral fat, and that is troublesome for our population. That's why we are seeing a lot of diabetes early in the course of the person's life, and we see the mortality early in the course of life. So it improves the visceral fat, it reduces the body weight and adipocyte hypertrophy. This is the graph showing the LDL-HDL by introduction of empagliflozin, and if anything, there's a neutral effect. But as I said, more dense lipoproteins are reduced. So as a result, if you look at the EMPA-REG cardiovascular outcome summary, there was a 14% reduction in 3-point MACE, there was 38% reduction in CV deaths, and there was all-cause mortality reduction by 32%, and overall the hospitalization because of the heart failure in patients with diabetes were reduced by 35%. So part of these effects are directly because of the SGLT2, but one would argue and one would need to start to think that is there any other role? And we have just seen that yes, it works on hypoglycemia, it works on microalbumin because that's another element which will cause increased morbidity and mortality, and also it works on the lipid profile. So one would think that these may be the effects of all this, but these are the direct effects seen for the cardiovascular outcome in patients. The next is hyperuricemia and kidney stone. When we are treating patients with diabetes, one doesn't think about these additional things of renal nephrolithiasis and kidney stones and uric acid. But we know that uric acid is a risk factor, cardiovascular risk factor equivalent for patients. So at least this is our concern. If this is not, if this isn't, so there is a hypothesis that it works, it competes with the urine and sodium glucose reabsorption at the tubule, and as a result, it actually reduces the uric acid in the blood. And there has been papers, multiple papers in fact, but 2-3 last few months, which shows that it actually is a cardioprotective by reducing the plasma uric acid level, and the potential mechanisms are by reducing the blood pressure and endoplasmic stress, decrease fibrosis, increase nitric oxide, which is required at the renal level. So these are additional effects. These are the effects which we probably may not look for, but this is what additional benefit does it have. There's a pooled analysis, meta-analysis of 62 randomized controlled trial involving almost 34,000 patients, and they quantified the uric acid lowering effect of SGLT2. The extent of serum uric acid reduction was seen with use of SGLT2. And this is that meta-analysis. So what is on your left side favors the serum uric acid reduction, and what is on your right side is increasing uric acid. So SGLT2 shows the benefit by reduction of uric acid, something which we may consider an additional benefit for patients using SGLT2 for type 2 diabetes. So in conclusion of uric acid studies, SGLT2 inhibitors were found in general to reduce the serum uric acid level, given the associated clinical disorders, hyperuricemia, uricemia may be beneficial, and as I said, particularly for cardiovascular outcomes. Plenty of studies, it somehow reduces the nephrolithasis. The mechanism is not clearly known, but that's another additional benefit. So patients with diabetes, long-standing diabetes, doesn't come with one disease. They don't come with two diseases. They come with a plethora of symptoms and diseases. And it is always beneficial that you kill two birds with one shot, because if there's additional benefit and that's helping, like any drug which we are using reduces the weight for type 2 diabetes, will be welcome. So we prefer to use the drugs which reduce the weight. Similarly, if these are additional benefit and somebody's got a renal stones along with diabetes and macroalbuminuria and hypertension and high uric acid, I think this is an additional benefit which I never thought of, and while preparing these slides, I looked in the literature and this is what we saw. Does it have effect on renal insufficiency and blood pressure? In all the trials, regardless of what SGLT2 you are using, Cana, DAPA, AMPA, or again Cana in this study, in all the studies, what it shows that it delays the renal replacement therapy. So it delays the end-stage renal disease. Yes, one has to be wary that if the EGFR is less than 30, it will not filter, so you don't need to use that drug below 30 of EGFR. But if it is above that, it's about 45, we can be using these drugs even at a 45 EGFR, that can be used. There's an analysis published which shows that it improves the kidney disease outcome in patients with or without heart failure. So yes, the patient has got diabetes, patient has got macroalbuminuria, patient may have a heart failure or no heart failure. Even in those cases, SGLT2 will improve the kidney outcomes in terms whether they have a heart failure or not. And this again, this meta-analysis is favoring that. In terms of GFR, in 966 patient eGFR was reassessed at the end of the trial for 42 days after the withdrawal of double-blind therapy, thus allowing the assessment effect of treatment. What it shows was that when compared to placebo, eGFR was actually not deteriorated as it was deteriorating in the placebo arm. So it maintained the eGFR to a better level. Yes, it was reduced, but it maintained compared to placebo. So additional benefit that you saw. It has been used even in acute kidney injury. I'll be very bold to use that, but generally the literature shows that it's safer to use even in acute kidney disease and SGLT2 molecules. Whether it works, there's so much talk about fatty liver disease these days and NASH and all that. Whether it can be used, there is a trial, Umar is not here. We are working on a drug to be used in NASH, for that matter, to see what happens in Pakistani population. But whether there is a literature to show that it improves the liver functions in fatty disease, it reduces the ALT and gamma GT compared to control in patients. And this is what it shows, that post-treatment there was a significant hepatic fat content reduction in patients who were using empagliflozin compared to placebo. So again, some suggestion that even another risk factor that we have for fatty liver in patients with diabetes, uncontrolled diabetes, and even with patients who are controlled, but they have fatty liver, so it has got improvement in fat liver as well. So in this trial, when included to a standard treatment of type 2 diabetes, it reduces the liver fat and improves the AT levels, which will be welcome for patients with type 2 diabetes and SALD. What about congestive heart failure and atrial fibrillation? I think there's enough evidence to suggest that it improves the outcomes of the heart failures, and in fact it's a drug. If you see the recommendations of the European Association, in fact if you see the recommendation of the Heart Association, there the SGLT2 comes before even if they are non-diabetic. So it's a part of the treatment of heart failure now. But what is important to say is that the benefit of SGLT2 is seen very early in the disease. So the moment you start, if patient has got a heart failure, the diversion of these graphs is right from the beginning. When you do these trials, you see the diversion of the curves very late in the disease. But here we are seeing the improvement in cardiac failure in patients in this EMPA-REG outcome trial, and it is very impressive in terms of, if you look at all-cause mortality, that is about 32%. If you look at CV mortality, that's about 38%. If you look at heart failure and hospitalization, that's about 35%. So all very impressive figures if somebody has got diabetes, protein leak, heart failure. That's a drug which you can use with some certainty in terms of improvement in outcomes of cardiovascular mortality. And this is what it shows, the EMPA-REG trial, that the heart failure is reduced by 35%. Atrial fibrillation, directly no effect, and we talk about the atrial fibrillation when we talk about GLP-1 analogs, because they have got a center on the SA node and AD node. But what it shows was that when we were using, this drug was used in patients who have a heart failure and have an atrial fibrillation on top of it, there was a reduction in terms of outcomes, in terms of death because of heart failure and all-cause mortality when we were using. So the mechanism is not probably directly related to atrial fibrillation, but it did show reduction in the all-cause mortality and CV deaths when the empagliflozin was used in these patients. With normal ejection fraction, that is something which is coming very, very favorite these days, that you can use this drug even if they don't have a reduced ejection fraction. So there is a definition of reduced ejection fraction, heart failure with reduced ejection fraction, which means LV ejection fraction of less than 40. Then there is preserved ejection fraction, which is more than 50. And then there is a mid-range ejection fraction. So regardless of any kind of a heart failure or no heart failure or preserved ejection fraction, the outcome has been shown to be better when you're using SGLT2. And this is the glucose delivering medications, and if you look right at the top, the heart failure is there. So basically when you're using SGLT2 in your patients with diabetes, yes, it has got effect on glucose lowering effect, it's got effect on microalbuminuria. But what is important is that now we classify whether the patient has got a heart failure to begin with, whether the patient has got a renal disease to begin with when you're managing the patient with diabetes. If they've got that two diseases, straight away in the algorithm, you will get SGLT2 straight away in those patients. So something which we need to consider when we are managing our type 2 diabetes patients who are not very well controlled. Blood pressure, there is a definite reduction of at least 10 millimeter of systolic blood pressure, which we have seen in our own study. Definite reduction and slight reduction, 4 to 5 millimeter of reduction in the blood pressure. We know that most of our patients with diabetes have got a hypertension, most of them, 70 to 80% of them. And most of them are not controlled on 1, 2 or 3 drugs. So any benefit, additional benefit that we will get from SGLT2 in reducing the blood pressure. Sometimes they are diuretics, and we have seen that when we introduce this drug, the diuretic dose has to be adjusted for those patients. There was a worry whether these drugs cause hyperkalemia, but we have seen that the effect of sodium, potassium, and natriuresis, glycoside, there's a lot happening in the kidney, but the general consensus was that it doesn't affect the potassium in patients with diabetes using these drugs. So the net effect of potassium, potential low increase of serum potassium and magnesium concentration was balanced, which means that the patient didn't have any effect on hyperkalemia, which was one of the worries when you are seeing patients in which there's a natriuresis and glycoside that was not seen. And these are the study which was shown on 24 weeks of pooled population. There was no effect on potassium itself. And this again showed a neutral. So there was no effect of hyperkalemia or hypokalemia in patients using these drugs. Weight loss. Does it cause weight loss? Yes, it does, and according to some studies, a weight loss of about 4 to 5 kilos, which means that you are losing at least 300 to 400 calories a day in patients using SGLT2. Again, in the context of patients with type 2 diabetes, who are usually obese. So if they are losing weight, any weight loss is welcome. If you compare this with glimepiride, no doubt, which causes weight gain. But if you are looking at SGLT, there is definitely reduction in fat mass compared to glimepiride. So any drug which brings the weight down is welcome in diabetes. And this drug has shown a weight reduction compared to glimepiride and sulfonylurea. Remember, our patient was on glimepiride, which will cause further weight gain. So 80% reduction in weight mass compared to sitagliptin. Again, here's the sitagliptin, and here's your empagliflozin 10 and 25 milligram, and there's definitely a weight loss in patients with diabetes. So another benefit, dry eyes. That is something which is not very much thought of, but there's an inflammation in the eyes in patients with type 2 diabetes. Somehow it has been shown that it reduces the inflammatory markers in the eye, something which patients may or may not tell you, but these are the additional benefits that we see. So when compared to women, to men, there's more dryness of eyes in women, and it improves the dryness of eyes by reducing the inflammation in the eyes. So with all these good things, is there anything bad about them? That we need to do. My consultant, where I was trained in the UK, they used to say, when you're doing a procedure, when you're using a drug, you need to know how to tackle the problems related to a drug or to a procedure. And that applies here. So does it cause any issues? Yes. One of the major issues is that it causes lipolysis, and it increases the free fatty acid delivery to the liver, and hence the chances of a decay are there. We, in practice of since the drug has been there, we have seen just one case so far in our clinical practice, not many, but something you need to be considered. And again, it brings the importance that you cannot use this drug in patients who are insulin-obedient, because the chances of ketosis will be very high if they are insulin-obedient. Although in trials they have used in some of type 1 patients, obese type 1 patients as well. But I think you have to be very brave to use these drugs in patients who are insulin-dependent because of the chances of the euglycemic decay. So that has to be considered. The other issues it has maybe was increased risk of amputation. That was seen in canagliflozin initially, but then the warding was reduced because of the EMPEROR trial and many other trials. So that warding that black box of warding has been taken out, but that was only seen for canagliflozin. It is not for all the other SGLT2 inhibitors. So this is an observational study, and they have said that the below knee amputation risk is not for every SGLT2 inhibitor. Is there a chance of urinary tract infection? This is the studies done which says it is almost similar to placebo in the bigger studies. These were the effects seen in placebo. So we were seeing infection in the urine of patients using placebo compared to empagliflozin, almost matching, and there was almost matching in this trial, EMPEROR trial, the urinary tract infection. Something you need to consider. There's a one caveat which I would say. This is our own study in which we have shown that we've done a safe path study, and what it showed was, in fact, it was more in the control group compared to the intervention group. Infection, urinary tract infection. We actually published another paper saying that patients with diabetes have got a high risk of urinary tract infection anyway, and that's what we showed in that paper. What is important is if your patient is above 45 and female and has got a history of urinary tract infection, this is the conclusion of our own study. You should be careful in treating them with SGLT2 because the chances of urinary tract infection being treated. That's all from me. So it's a